All right, everyone. Welcome to week 3 of HTL 312. This week, we're stepping into one of the most complex areas of healthcare ethics, the end-of-life decision-making and patient consent. These are the types of topics that move ethics from something theoretical that you read about in a textbook into situations that affect real people, real families, and real healthcare teams. Now, when people think about end-of-life ethics, they often picture physicians or nurses having those very difficult conversations with families at the bedside. And yes, they absolutely play a central role. But what's important to recognize is that these decisions rarely happen in isolation. They rely on information coming from across the healthcare system, including the laboratory. For example, laboratory data can confirm the presence of terminal disease, monitor the progression of organ failure, guide treatment options, and sometimes even contribute to determinations related to brain death. In other words, the information produced in the laboratory often helps shape the clinical picture that physicians use when making extremely serious decisions. So while histotechnologists and laboratory professionals may not be present in those bedside discussions, our work is very much part of the decision-making environment that surrounds them. This lecture will help you understand the ethical principles and legal concepts that guide those decisions, particularly autonomy, informed consent, capacity, and the right to refuse treatment. The goal here is not to turn you into healthcare ethicists overnight. The goal is to help you recognize how ethical reasoning works in real healthcare environments and how your role in the laboratory contributes to responsible patient care. Before we dive into definitions and frameworks, let's talk about why this topic matters in the first place. End-of-life discussions are widely considered some of the most ethically challenging situations in medicine. They involve questions that don't have simple answers. For example, when should life-sustaining treatment continue, and when might it be appropriate to stop? Who gets to make that decision? And what happens when different people involved in the situation disagree? According to Posgar, many of these situations revolve around the concept of patient self-determination, meaning patients have the right to make decisions about their own medical care whenever possible. But real life is messy. Patients may become unconscious, confused, or otherwise unable to communicate their wishes. When that happens, healthcare teams must look to other sources of guidance, such as advance directives, family members, or legal surrogates. Another reason these situations are complex is because they often involve multiple perspectives at the same time. Physicians bring medical judgment, families bring emotional and personal perspectives, hospitals bring legal responsibilities and policies, and the patient's previously expressed wishes must remain central to the process. Balancing those perspectives requires careful ethical reasoning. Healthcare professionals have to ask questions like, are we respecting the patient's autonomy? Are we acting in their best interest? Are we causing harm or preventing harm? And are we using medical resources responsibly? These are not simple checklist questions. They require thoughtful discussion and professional judgment. That's why understanding ethical frameworks is so important. They give healthcare professionals a structured way to think through difficult decisions instead of reacting emotionally or impulsively. This slide gives you a roadmap for what we'll cover in today's lecture. We'll start by looking at end-of-life ethical dilemmas, which often involve situations where continuing treatment may prolong life, but not necessarily improve quality of life. These decisions are rarely straightforward and often require balancing multiple ethical principles at once. Next, we'll talk about patient autonomy, which is one of the most important ethical principles in modern healthcare. Autonomy means that patients have the right to make decisions about their own bodies and medical treatment, even if those decisions differ from what healthcare providers might recommend. Then we'll move into informed consent, which is the process that allows patients to make those decisions responsibly. Informed consent isn't just signing a form. It's a process of communication where patients are given enough information about a treatment or procedure to understand the risks, benefits, and alternatives. Closely related to that is the concept of capacity, which refers to whether a patient is able to understand information and make decisions about their care. Capacity can change depending on a person's medical condition, medications, or cognitive status. We'll also discuss the right to refuse treatment, which sometimes surprises people. Patients have the legal and ethical right to refuse medical care, even if the decision could result in their death. Finally, we'll look at how decisions are made for patients who cannot speak for themselves, which is where surrogate decision makers and advance directives come into play. Throughout all of this, we're going to keep returning to the same central question. How do these ethical principles influence real healthcare decisions, and where does the laboratory fit into that picture? Let's dig a little deeper into why end-of-life ethics is such a significant topic in healthcare. As Poscar explains, these decisions often involve several factors happening at the same time. First, there's patient autonomy, which means respecting what the patient wants for their own medical care. But patients may not always be able to express those wishes, especially if they are unconscious or cognitively impaired. Second, there is medical judgment. Physicians must consider whether treatments are likely to help the patient or simply prolong suffering without improving outcomes. Third, families often play an important role in these situations. Family members may have strong emotional responses, personal beliefs, or cultural values that influence how they think decisions should be made. Sometimes family members agree with each other, and sometimes they absolutely do not. Fourth, there are legal considerations. Healthcare providers must follow laws and policies regarding informed consent, advance directives, and decision-making authority. And finally, there are institutional policies. Hospitals and healthcare systems have ethical committees and guidelines designed to help navigate these situations. All of these factors interact at the same time. Healthcare teams must balance these responsibilities while maintaining respect for patient dignity and professional standards. That's why ethical reasoning is such an essential skill in healthcare. Even though laboratory professionals are not the ones making final treatment decisions, the information we generate often contributes to the clinical picture that guides those decisions. So understanding this ethical framework helps you see how your work fits into the larger healthcare system. Now let's talk about where laboratory medicine fits into all of this. Because at first glance, it may seem like end-of-life decisions happen entirely outside the lab. Most of the time, laboratory professionals are not standing at the bedside when those conversations occur. We're not the ones discussing treatment plans with families or explaining prognosis directly to patients. But that doesn't mean the laboratory is disconnected from those decisions. In reality, laboratory data often plays a major role in the clinical information physicians use when making very serious decisions about patient care. Think about situations involving life-limiting diseases. A biopsy processed in histology may confirm metastatic cancer. That diagnosis may shape treatment plans, palliative care discussions, or decisions about aggressive therapy versus comfort-focused care. Laboratory testing is also essential for monitoring organ failure. Lab values for things like liver function, renal function, and electrolyte balance help clinicians determine how well a patient's body is functioning and whether treatment is helping or simply prolonging suffering. Another example involves brain death determination. While clinical neurologic examinations are central to that process, laboratory tests and supporting diagnostics often help rule out reversible conditions that could mimic brain death. So while the laboratory may feel like a step removed from these decisions, our work provides the evidence that informs medical judgment. This is why ethical laboratory practice matters so much. If results are inaccurate, rushed, or poorly documented, the information guiding clinical decisions could be flawed. In other words, the ethical responsibility of laboratory professionals is not just about doing the test correctly. It's about recognizing that the results we generate contribute to life-altering medical decisions across the healthcare system. To understand how healthcare teams approach end-of-life decisions, we need to revisit four core ethical principles that guide medical practice. These principles are discussed extensively in healthcare ethics literature and are also emphasized in Poscar's discussion of clinical decision-making. The first principle is autonomy. Autonomy refers to respecting a patient's right to make decisions about their own body and medical care. In modern healthcare, autonomy is extremely important because it recognizes patients as active participants in their treatment rather than passive recipients of care. Second is beneficence, which means acting in the patient's best interest. Healthcare professionals are expected to recommend treatments that promote patient well-being and improve health outcomes whenever possible. Third is non-malfeasance, which literally means do no harm. This principle reminds healthcare providers to consider whether an intervention might cause unnecessary harm, suffering, or risk to a patient. Finally, we have justice, which refers to fairness in healthcare. Justice includes equitable access to care and responsible use of medical resources. Now here's where things become complicated. In real healthcare situations, these principles do not always align perfectly. A patient may exercise autonomy by refusing treatment, even if healthcare providers believe continuing treatment could benefit them. A physician may believe stopping treatment avoids harm, while family members believe every possible intervention should continue. End-of-life care often requires balancing these principles rather than applying only one of them. Understanding these ethical foundations helps healthcare professionals reason through complex situations rather than relying on personal opinion or emotion alone. This slide introduces something that happens frequently in healthcare ethics: conflicts between ethical principles. In textbooks, ethical principles can appear neat and organized. But in real life, situations often involve competing priorities where two or more ethical principles point toward different decisions. For example, imagine a patient who clearly expressed their wish not to receive life-sustaining treatment if their condition became terminal. That situation strongly reflects the principle of autonomy because the patient has the right to determine what happens to their body. However, family members may strongly disagree. They may believe continuing treatment is the best way to preserve life, which they see as honoring the principle of beneficence. Another example involves the balance between prolonging life and maintaining quality of life. Medical technology allows us to sustain bodily functions far longer than in the past, but sometimes continuing treatment may extend life without improving the patient's experience or comfort. Healthcare teams must also consider medical futility, which refers to treatments that are unlikely to produce meaningful benefit for the patient. These situations create ethical dilemmas, not because someone is behaving unethically, but because different ethical priorities are pulling in different directions. In these moments, healthcare professionals rely on ethical frameworks, clinical judgment, patient preferences, and sometimes ethics committees to help to determine the most responsible course of action. Ethical decision-making in healthcare is rarely about finding a perfect answer. It's about making the most ethically defensible decision possible given the circumstances. Now that we've explored why these ethical issues matter and how ethical principles interact, we're going to move into the next section of the lecture, which focuses on defining end-of-life decision-making. End-of-life care refers to the medical care and decision-making that occurs when a patient is approaching the final stage of life. This stage may occur because of advanced illness, severe injury, or progressive organ failure. One important thing to understand is that end-of-life care is not solely about stopping treatment. In many cases, it focuses on improving quality of life, managing symptoms, and supporting patient dignity. For example, patients receiving hospice care may still receive medications, treatments for pain or discomfort, and supportive services that improve comfort and emotional well-being. Another key concept is that end-of-life decision-making is rarely handled by a single individual. Instead, it typically involves interdisciplinary healthcare teams that may include physicians, nurses, social workers, chaplains, and sometimes ethics committees. These teams work together to evaluate medical information, consider patient wishes, communicate with family members, and determine the most appropriate course of care. Once again, the laboratory plays an indirect but important role here. Diagnostic tests, pathology results, and laboratory monitoring often contribute to understanding disease progression and prognosis. In other words, the laboratory provides part of the clinical evidence that helps healthcare teams evaluate whether treatments are helping, harming, or no longer providing meaningful benefit. As we move through the next part of the lecture, we'll look more closely at how end-of-life care is defined in medicine and how healthcare professionals approach these situations in practice. So now that we've introduced the concept of end-of-life decision-making, let's start with a basic question. What exactly is end-of-life care? End-of-life care refers to the medical care and decision-making that occurs when a patient is approaching the final stage of life. That might sound straightforward, but in practice it's actually a pretty complex concept. There isn't always a clear line where someone suddenly transitions into what we label as end of life. Sometimes it happens gradually as a disease progresses. For example, in advanced cancer, severe heart failure, or progressive neurodegenerative diseases like ALS. In other cases, it might occur more suddenly, such as after catastrophic trauma or severe brain injury. The goals of end-of-life care are often very different from the goals of curative medicine. Instead of focusing on curing disease, healthcare teams often shift toward comfort, symptom management, and maintaining dignity for the patient. This might include pain control, respiratory support for comfort, emotional support for the patient and family, and careful consideration of which treatments are actually beneficial. Another key goal is respecting patient wishes. This is where autonomy becomes incredibly important. If patients have expressed preferences about treatments they do or do not want, such as resuscitation, mechanical ventilation, or feeding tubes, healthcare teams are ethically obligated to consider those wishes. End-of-life care also involves avoiding treatments that may be medically unnecessary or harmful. Just because medicine can do something doesn't always mean it should. Ultimately, the goal is to balance medical care with compassion, dignity, and respect for the patient as a person, not just as a medical case. When we talk about end-of-life care, it's also important to understand where patients actually receive that care, because the environment often influences how decisions are made. Many people assume most deaths occur in hospitals, but in reality, patients may spend their final days in a variety of settings. Hospitals are certainly one common location, especially when patients are critically ill or receiving intensive medical treatment. In those situations, decisions about life support, ventilators, or aggressive interventions may take place in the ICU. Another setting is long-term care facilities, such as nursing homes. Many elderly patients with chronic illnesses or dementia receive end-of-life care in these facilities. In these environments, decisions often focus on comfort, managing chronic conditions, and honoring advance directives. You'll also hear about hospice care, which is specifically designed for patients with terminal illnesses who are expected to have a limited life expectancy. Hospice care focuses almost entirely on comfort, symptom management, and emotional support rather than curative treatment. And finally, many patients receive end-of-life care at home, surrounded by family members. Each of these environments presents unique challenges. Hospitals may involve complex technology and urgent decisions. Homes and hospice environments may focus more heavily on family involvement and comfort. Regardless of the setting, healthcare professionals must navigate the same ethical responsibilities, respecting patient wishes, communicating clearly with families, and making decisions that balance medical judgment with compassion. Another important concept we need to understand is how death is defined in modern medicine, because historically that definition has actually evolved over time. For much of medical history, death was defined primarily by cardiopulmonary criteria, meaning the heart and lungs stopped functioning. If the heart stopped beating and breathing stopped, the individual was considered dead. That definition still applies in many situations today. Cardiopulmonary death refers to the irreversible cessation of heart and lung function, meaning circulation and respiration cannot be restored. However, advances in medical technology complicated that definition. Mechanical ventilators and advanced life support systems can sometimes maintain heart and lung function even when the brain has completely stopped functioning. Because of that, medicine also recognizes the concept of brain death, which refers to the irreversible loss of all brain function, including the brainstem. When brain death occurs, the individual has permanently lost the capacity for consciousness and independent breathing. Now here's where laboratory medicine can intersect with this process. While brain death determination is primarily based on clinical neurological examinations, laboratory testing often helps support the evaluation. For example, lab tests may help rule out metabolic abnormalities, toxic exposures, or electrolyte disturbances that could mimic neurological dysfunction. So once again, laboratory professionals may not be making the final determination of death, but the information we provide can help ensure that clinical conclusions are accurate and medically sound. As you can probably imagine by now, end-of-life care raises some very difficult ethical questions. One of the most common questions is when life-sustaining treatment should stop. Medical technology allows us to maintain biological function in ways that would have been impossible decades ago. Ventilators, dialysis machines, and advanced medications can sustain life for extended periods. But sometimes healthcare teams must ask whether continuing treatment is actually helping the patient or simply prolonging suffering. Another major question is who should make decisions when patients cannot speak for themselves. Patients may be unconscious, cognitively impaired, or otherwise unable to communicate their wishes. In those situations, decision-making authority often shifts to surrogate decision makers, such as family members or legally appointed healthcare proxies. This leads to another complicated issue. How much weight should be given to family wishes? Families often care deeply about the patient and want what they believe is best, but their preferences may not always align with what that patient previously expressed. And sometimes the patient's wishes are simply unknown. Maybe no advance directive exists, and the patient never had conversations with family members about their preferences. In situations like this, healthcare teams must carefully evaluate medical evidence, ethical principles, and family perspectives in order to determine the most appropriate course of action. These situations remind us that healthcare ethics is rarely about easy answers. It's about making thoughtful decisions in situations where the stakes are incredibly high. All right, now we're moving into a topic that tends to generate a lot of discussion anytime it comes up in healthcare ethics courses: euthanasia and assisted death. This is one of those areas where ethical principles, legal frameworks, cultural values, and personal beliefs often intersect in complicated ways. People tend to have strong opinions about it, and those opinions are often shaped by religious beliefs, personal experiences, or societal perspectives about suffering and dignity. From an ethics standpoint, the topic is closely tied to many of the principles we discussed earlier, especially autonomy, beneficence, and non-malfeasance. For example, one argument often raised in support of assisted death centers around autonomy. If patients have the right to make decisions about their own bodies and medical care, some argue that this right should include decisions about how and when their life ends in situations involving severe suffering. At the same time, healthcare professionals must also consider beneficence and non-malfeasance, meaning acting in the patient's best interest and avoiding harm. Those principles can raise serious questions about whether intentionally ending life aligns with the fundamental goals of medicine. Legally, this is also a highly regulated area. Laws vary significantly depending on the country, and even within the United States, different states have different policies regarding physician-assisted dying. For our purposes in this course, the goal is not to debate personal beliefs, but to understand the ethical frameworks and professional considerations that healthcare providers must navigate when these issues arise. Understanding these concepts helps healthcare professionals participate thoughtfully in discussions that may involve patients, families, medical teams, and legal systems. So let's start by defining the term euthanasia. Euthanasia generally refers to intentionally ending a person's life in order to relieve suffering. The word itself comes from Greek roots meaning good death, which reflects the idea that the action is intended to reduce pain or distress for someone experiencing severe illness. Now, even that definition immediately raises complex ethical questions. Who determines when suffering is severe enough? Who has the authority to make that decision? And what safeguards exist to prevent abuse or coercion? These questions are why euthanasia is such a heavily debated issue in healthcare ethics. From a legal standpoint, euthanasia is illegal in most countries and most United States states. However, some jurisdictions allow forms of physician-assisted dying under very specific regulations and oversight. It's also important to distinguish euthanasia from other end-of-life decisions we've already discussed. For example, choosing to withdraw life-sustaining treatment or honoring a patient's decision to refuse treatment is not typically considered euthanasia. Those decisions are generally understood as respecting patient autonomy rather than intentionally causing death. Healthcare professionals must carefully navigate these distinctions because the ethical and legal implications are very different. In clinical practice, discussions about euthanasia often lead into broader conversations about palliative care, hospice care, patient autonomy, and managing suffering at the end of life. So again, the key takeaway here is understanding the ethical complexity, not memorizing a single right or wrong answer. Discussing euthanasia in healthcare ethics, it's common to divide the concept into two broad categories: active euthanasia and passive euthanasia. Active euthanasia refers to situations where a direct action is taken with the intention of ending a patient's life. For example, administering a medication specifically intended to cause death would fall into this category. Because this involves a deliberate action to end life, active euthanasia is illegal in most jurisdictions and raises significant ethical concerns within the medical profession. Passive euthanasia, on the other hand, refers to allowing death to occur by withholding or withdrawing medical treatment. This might involve decisions not to initiate life support, not to perform CPR, or discontinuing treatments that are no longer beneficial to the patient. This distinction is where things get interesting in healthcare ethics. Many ethical frameworks consider passive euthanasia ethically permissible when it aligns with patient wishes and when continued treatment would be medically futile or harmful. In these cases, the goal is not to cause death, but rather to allow the natural disease process to take its course while focusing on comfort and dignity. This distinction is discussed frequently in healthcare ethics literature, including Poskar's work, because it highlights the difference between intending death and allowing death to occur when treatment no longer benefits the patient. Understanding this difference helps healthcare professionals evaluate complex situations while remaining consistent with ethical standards and legal guidelines. Another important distinction involves whether the patient has actually requested the action, which brings us to the difference between voluntary and involuntary euthanasia. Voluntary euthanasia occurs when a patient knowingly and intentionally requests assistance in ending their life. In ethical discussions, this is often connected to the principle of autonomy, because the patient is expressing a personal decision regarding their own suffering and medical care. However, even in jurisdictions where physician-assisted dying is permitted, strict safeguards typically exist. These may include requirements for mental competency, evaluations, multiple physician consultations, waiting periods, and documentation of informed consent. Involuntary euthanasia, on the other hand, occurs when a person's life is ended without their consent or without their ability to provide consent. This raises profound ethical concerns and is widely considered unethical and illegal. Modern healthcare ethics places a very strong emphasis on voluntary decision-making and informed consent. Patients must be capable of understanding their situation and making decisions freely without coercion. For healthcare professionals, this enforces the importance of communication, documentation, and ethical accountability. Decisions about life and death must be handled with extreme care, transparency, and respect for patient autonomy. Even when healthcare providers personally disagree with a patient's choices, ethical practice requires respecting the patient's rights whenever those decisions are informed and voluntary. And that principle, respecting patient autonomy while maintaining professional responsibility, is something we'll see again when we move into the next section on advanced directives and patient consent. Another concept closely related to euthanasia is physician-assisted suicide, sometimes called physician-assisted dying. In this situation, the physician does not directly cause the patient's death, but instead provides the means for the patient to end their own life. Typically, this involves prescribing a medication that the patient may choose to take on their own. The distinction here is important from both a legal and ethical perspective. In physician-assisted suicide, the final action is taken by the patient, not by the physician. Because of this distinction, some jurisdictions treat physician-assisted suicide differently than euthanasia under the law. In the United States, the legal status varies by state. Several states allow physician-assisted dying under strictly regulated conditions. These regulations often include requirements such as confirmation of a terminal illness, multiple physician evaluations, mental competency assessments, waiting periods, and formal documentation of informed consent. The intention behind these safeguards is to protect patient autonomy while also preventing coercion or abuse. From an ethical standpoint, this topic again raises important questions. Supporters often emphasize autonomy and relief of suffering, while critics may raise concerns about the role of healthcare providers in intentionally facilitating death. As future healthcare professionals, even those working in laboratory fields, understanding these debates help you better understand the broader ethical environment in which healthcare operates. Now we're moving into a concept that plays a major role in end-of-life decision-making: advanced directives. Advanced directives are tools that help communicate a patient's wishes about medical care before a crisis occurs. They are especially important when patients become unable to speak for themselves due to illness, injury, or loss of consciousness. Think about many of the ethical questions we discussed earlier. Questions like who should make decisions when patients cannot communicate, or how we know what treatments a patient would want. Advanced directives are designed to answer those questions in advance. These documents allow individuals to express their preferences about treatments such as resuscitation, life support, mechanical ventilation, or artificial nutrition and hydration. In many ways, advanced directives are one of the strongest ways healthcare systems support the ethical principle of patient autonomy. They provide guidance not only for physicians, but also for nurses, healthcare teams, and family members who may otherwise be forced to make extremely difficult decisions without knowing the patient's wishes. In healthcare settings, including hospitals and long-term care facilities, these documents often become part of the patient's medical record so that care teams can reference them when important decisions arise. Let's look a little more closely at what advanced directives actually are. Advanced directives are legal documents that communicate a patient's wishes about medical care if they become unable to make decisions for themselves. In other words, they allow individuals to speak for themselves in advance before a situation occurs where they might be unconscious, cognitively impaired, or otherwise unable to communicate. This becomes incredibly important during serious illness or medical emergencies, where decisions about treatment may need to be made quickly. Without guidance from the patient, healthcare providers and families may struggle to determine what the patient would have wanted. Advanced directives help reduce that uncertainty. They guide physicians and healthcare teams when determining treatment options, and they also provide families with reassurance that they are honoring their loved one's wishes rather than making those decisions entirely on their own. From an ethical perspective, advanced directives reinforce autonomy, but they also support beneficence and non-malfeasance by helping clinicians avoid treatments that the patient would not want. In other words, they help ensure that care decisions align with the patient's personal values, beliefs, and preferences. There are several common forms of advance directives, each serving a slightly different purpose. One of the most familiar is the living will. A living will allows a person to describe specific medical treatments they would or would not want in situations involving serious illness or end-of-life care. For example, it may address preferences about mechanical ventilation, feeding tubes, or resuscitation. Another important document is the Durable Power of Attorney for Healthcare, sometimes called a healthcare proxy. This document allows a patient to designate another person to make medical decisions on their behalf if they become unable to do so themselves. That person, often a spouse, family member, or trusted friend, becomes responsible for representing the patient's wishes when communicating with healthcare providers. You may also hear about medical orders such as DNR orders, meaning do not resuscitate, or POLST forms, which stand for Physician Orders for Life-Sustaining Treatment. Unlike some advance directives that are completed earlier in life, POLST forms are typically used for patients with serious illness and translate patient preferences into actionable medical orders. Together, these documents help guide healthcare teams during complex or emotionally difficult medical situations. They ensure that decisions remain focused on respecting the patient's wishes while providing compassionate care. Let's start with one of the most well-known forms of advance directives, the living will. A living will is a document that allows a person to outline their preferences for medical treatment in the event that they become incapacitated and are unable to communicate those wishes themselves. In other words, it's a way for patients to say ahead of time, if I'm in this type of medical situation, here's what I would want, and here's what I would not want. Living wills often address decisions involving major life-sustaining interventions. For example, they may include preferences about mechanical ventilation, which is when a machine assists or replaces breathing. They may also address feeding tubes, CPR, or other forms of intensive medical support. Now, something important to understand is that these decisions are not always simple yes or no situations. Medical circumstances can vary widely, so living wills often try to describe situations where a patient might want treatment continued versus situations where they might prefer comfort care instead. For example, someone might state that they would accept aggressive treatment if recovery is possible, but would not want prolonged life support if they were in a permanent vegetative state. From an ethical perspective, living wills help support the principle of patient autonomy because they allow individuals to maintain control over medical decisions even when they cannot physically communicate. And from a practical standpoint, they also help families and healthcare teams avoid uncertainty during emotionally difficult situations. If a patient's wishes are clearly documented, healthcare providers are better able to respect those wishes while delivering care that aligns with the patient's values. Another extremely important type of advance directive is the Durable Power of Attorney for Healthcare. This document allows a patient to appoint a trusted individual who will make medical decisions on their behalf if they become unable to make those decisions themselves. The person selected for this role is often referred to as a healthcare proxy, healthcare agent, or surrogate decision maker. This role carries a significant responsibility. The person chosen is expected to represent the patient's wishes, not necessarily their own personal opinions. Ideally, the individual selected should understand the patient's values, beliefs, and preferences about medical care. This is why healthcare professionals often encourage patients to have conversations with their chosen proxy before a medical crisis occurs. For example, someone might say to their healthcare proxy, if I were ever in a situation where recovery wasn't possible, I would want comfort care instead of aggressive treatment. Those conversations help ensure that if the proxy ever needs to make decisions, they are doing so based on the patient's wishes rather than guessing. From an ethical standpoint, durable power of attorney for healthcare again reinforces autonomy, but it also supports beneficence because it helps ensure decisions are made in the patient's best interests when they cannot advocate for themselves. In real healthcare settings, these documents can be incredibly valuable in helping care teams navigate complex decisions while maintaining respect for the patient's preferences. Even with advanced directives in place, there are still situations where surrogate decision makers become essential. Surrogate decision makers Surrogate decision-making occurs when healthcare providers rely on another individual to make medical decisions because the patient is unable to do so. This surrogate may be a spouse, adult child, legal guardian, or someone formally designated as a healthcare proxy. Different states and healthcare systems have slightly different legal hierarchies that determine who may serve as a surrogate if a formal proxy has not been appointed. For example, in many situations, the first surrogate decision maker is typically the patient's spouse, followed by adult children or other close relatives. But the key responsibility of a surrogate is not simply to make decisions based on what they personally think is best. Instead, they are expected to use what's called substituted judgment. This means the surrogate tries to make the decision the patient would have made if they were able to speak for themselves. If the patient's wishes are unknown, then the surrogate and healthcare team may rely on the best interest standard, which focuses on choosing the option most likely to benefit the patient and minimize suffering. These decisions can be emotionally difficult for families, which is why advanced directives and early conversations about care preferences are so important. When patients communicate their wishes clearly, it reduces the burden on family members who might otherwise have to make those decisions during moments of crises. Now we're moving into another important ethical topic, withdrawing or withholding medical treatment. These terms refer to situations where healthcare providers either do not start a treatment or stop a treatment that has already begun. At first glance, this might sound controversial, but in many healthcare situations, it is considered both ethically and legally appropriate. Withholding treatment means deciding not to initiate a medical intervention. For example, a patient may decide they do not want to be placed on a ventilator or do not want resuscitation attempts if their heart stops. Withdrawing treatment refers to stopping a treatment that is already in place, such as removing life support or discontinuing dialysis when it no longer aligns with the patient's wishes or medical goals. Ethically, healthcare providers generally view withholding and withdrawing treatment as morally equivalent. The focus is not on whether treatment started or stopped, but rather on whether the care being provided aligns with the patient's preferences and medical best interests. These decisions are often guided by advanced directives, discussions with surrogate decision makers, and careful evaluation by healthcare team. One important takeaway here is that choosing not to continue aggressive treatment is not the same as abandoning the patient. Instead, care often shifts towards palliative care, which focuses on comfort, symptom management, and quality of life. In many cases, this approach allows patients to spend their remaining time with greater dignity and less suffering. And ultimately, these decisions reflect the core ethical principles we've been discussing throughout this lecture: respect for autonomy, acting in the patient's best interest, and avoiding unnecessary harm. Let's start by looking more closely at withholding treatment. Withholding treatment means not initiating a medical intervention in the first place. In other words, the healthcare team and the patient, or the patient's surrogate decision maker, decide not to begin a treatment that could potentially prolong life. Some common examples include choosing not to start mechanical ventilation, declining CPR, or deciding not to begin dialysis. These decisions often arise when patients have serious illnesses and the potential benefits of treatment are uncertain, limited, or unlikely to improve quality of life. It's important to understand that withholding treatment is not about giving up on the patient. Instead, it often reflects a decision to focus on comfort, dignity, and quality of life rather than aggressive medical intervention. In many cases, these decisions are guided by advanced directives such as living wills or DNR orders. From an ethical standpoint, withholding treatment is generally considered acceptable when it aligns with patient autonomy and when the treatment would not provide meaningful benefit. One thing that students often find interesting is that many people feel emotionally more comfortable withholding treatment than withdrawing it, even though ethically they are viewed very similar. We'll talk more about that distinction in the next slide. Now let's talk about withdrawing treatment. which can sometimes feel more emotionally difficult but is ethically very similar. Withdrawing treatment means stopping a medical treatment that has already begun. Examples might include removing ventilator support, discontinuing medications that are sustaining life, or stopping dialysis treatments. For families and healthcare providers, this can sometimes feel like a more active decision than withholding treatment, because it involves stopping something that is already in place. However, most modern healthcare ethics frameworks, including those discussed by Posgar, view withholding and withdrawing treatment as ethically equivalent when decisions are guided by patient wishes and sound medical judgment. The key question is not whether treatment started or stopped. The key question is whether the treatment continues to serve the patient's goals of care. If a treatment no longer provides meaningful benefit or if it prolongs suffering without improving quality of life, withdrawing that treatment may be ethically appropriate. In these situations, care does not stop. Instead, the focus often shifts towards palliative care, which emphasizes symptom control, comfort, and emotional support. Healthcare professionals continue caring for the patient. The goals of care simply change. Even though healthcare ethics frameworks often treat withholding and withdrawing treatment similarly, these decisions can still create significant ethical debate. Many people struggle with the idea of stopping treatment, especially when life-sustaining technologies are involved. For example, families may feel that stopping a ventilator means actively causing death, even when the patient's underlying disease is what ultimately leads to death. These situations can create emotional stress for families and healthcare providers alike. Ethically, however, most healthcare guidelines emphasize that the patient's wishes and medical judgment should guide these decisions. If a patient has expressed preferences through advance directives, those wishes carry significant weight in guiding care decisions. If the patient cannot communicate, surrogate decision makers and healthcare teams work together to determine what the patient would likely have wanted. This is where communication becomes incredibly important. Healthcare teams must explain the medical situation clearly, discuss realistic outcomes, and support families through difficult decisions. Ethical decision-making in healthcare often involves navigating situations where there is no perfect answer, only the goal of acting with compassion, respect, and professional responsibility. The final concept we'll discuss in this section is medical futility. Medical futility refers to situations where a treatment is unlikely to produce any meaningful benefit for the patient. In other words, even though a treatment may technically be possible, it is extremely unlikely to improve survival, restore function, or enhance quality of life. This can occur in cases involving severe organ failure, advanced terminal illness, or catastrophic neurological injury. When healthcare providers determine that treatment is medically futile, they must carefully evaluate whether continuing aggressive interventions is actually helping the patient or simply prolonging suffering. These conversations can be difficult because families may still hope that continued treatment will lead to recovery. Healthcare providers must balance compassion with honesty when discussing realistic outcomes. From an ethical perspective, continuing futile treatment may conflict with the principles of beneficence and non-malfeasance, because it may expose patients to additional suffering without meaningful benefit. In these situations, healthcare teams often recommend shifting the focus toward palliative care and comfort measures, ensuring that the patient's remaining time is managed with dignity and symptom relief. Ultimately, medical futility reminds us that ethical healthcare decisions are not just about medicine. It's not just about what medicine can do, but also about what medicine should do in order to serve the patient's best interests. Another important directive that happens frequently in healthcare ethics discussions is the Do Not Resuscitate Order, commonly abbreviated as DNR. A DNR order instructs healthcare providers not to perform cardiopulmonary resuscitation, or CPR, if a patient's heart stops beating or if they stop breathing. CPR can involve chest compressions, defibrillation, medications, and sometimes emergency airway placement. While CPR can be life-saving in certain situations, it is not always beneficial for every patient, particularly those with severe or terminal illnesses. For patients with advanced disease or limited likelihood of recovery, CPR may cause additional trauma without improving survival outcomes. This is one reason why some patients choose to establish a DNR order. These decisions are often based on patient wishes, conversations with family members, and recommendations from healthcare providers regarding the likely outcomes of resuscitation. It is important to understand that a DNR order only applies to resuscitation efforts. It does not mean the patient stops receiving medical care. Patients with a DNR order still receive medications, treatments, comfort care, and support for their medical conditions. From an ethical standpoint, DNR orders support the principle of patient autonomy, allowing individuals to decide how aggressively they want life-sustaining interventions pursued. These decisions can be difficult emotionally, but they play an important role in ensuring healthcare aligns with the patient's values and goals of care. We are now moving into the next major topic in healthcare ethics, patient consent. Patient consent refers to the process by which a patient voluntarily agrees to receive a medical treatment, procedure, or intervention. In modern healthcare, consent is not simply a signature on a form. Instead, it represents a fundamental ethical principle that protects the patient's right to make decisions about their own body and medical care. Historically, medicine often operated under a more paternalistic model, where physicians made decisions for patients based on what they believed was best. Over time, healthcare ethics evolved to emphasize respect for patient autonomy, meaning patients should be active participants in their healthcare decisions. Consent ensures that patients maintain control over decisions affecting their health, their bodies, and their medical treatment. This principle applies across nearly every area of healthcare, from surgical procedures to diagnostic testing, medical administration, and participation in research studies. For consent to be ethically valid, patients must have the ability to understand the information presented to them and make a voluntary decision free from pressure or coercion. In other words, consent reflects the idea that patients should not just receive care, they should actively participate in decisions about their care. Let's break this concept down a little further. Patient consent refers specifically to a patient's voluntary agreement to receive medical treatment or undergo a procedure. The key word here is voluntary. Consent must be given freely, without pressure, manipulation, or coercion from healthcare providers or others. For consent to be valid, patients must also have decision-making capacity. This means they are able to understand the information provided, evaluate the potential options, and communicate a choice. If a patient is unconscious, cognitively impaired, or otherwise unable to make decisions, consent may instead come from a legally authorized surrogate decision maker, such as a healthcare proxy or guardian. Consent also reflects a broader ethical commitment to respecting individuals as autonomous decision makers. Healthcare providers may have recommendations based on medical expertise, but patients ultimately have the right to accept or refuse treatment. This can sometimes create challenging situations. For example, a patient might refuse a treatment that healthcare providers strongly recommend. In those cases, healthcare professionals must balance their duty to help patients with the ethical responsibility to respect the patient's right to make their own decisions. One of the most important forms of consent in healthcare is informed consent. Informed consent means the patients receive sufficient information about a medical procedure or treatment before agreeing to it. Simply asking a patient to sign a form without explanation would not meet the ethical standards of informed consent. Instead, healthcare providers must ensure that patients understand several important elements before making a decision. First, patients must understand the nature of the procedure or treatment, what will happen and why it is being recommended. Second, they should be informed about the potential risks and benefits associated with that treatment. Third, Patients should be told about alternative options, including the option of declining treatment altogether. And finally, they should understand the possible outcomes, including what might happen if the treatment is accepted or refused. This process allows patients to make decisions based on a clear understanding of their options. From an ethical perspective, informed consent directly supports patient autonomy, but it also strengthens trust between patients and healthcare providers. When patients feel informed and respected, they are more likely to feel confident in the care they receive and the decisions they make. Now that we've discussed what informed consent is, let's look at the key elements required for informed consent to be considered valid. There are four main components. Sorry about that. Four main components that must be presented for informed consent to meet both ethical and legal standards. The first is disclosure of information. This means healthcare providers must clearly explain the procedure or treatment being recommended. This explanation should include the purpose of the treatment, how it will be performed, and what the patient should expect. The second element is patient understanding. Providing information alone is not enough. The patient must actually understand what they are being told. This means explanation should be given in language that the patient can comprehend rather than using overly technical medical terminology. The third element is a voluntary decision. Patients must be able to make their choice freely without pressure from healthcare providers, family members, or other external influences. The final element is patient competence, sometimes referred to as decision-making capacity. The patient must be mentally capable of understanding the information and making a reasoned decision about their care. If any of these elements are missing, the consent may not be legally valid, and proceeding with treatment could raise serious ethical and legal concerns. These elements exist to ensure that healthcare decisions are made with respect for the patient's autonomy and personal values. So, why is informed consent such an important concept in healthcare ethics? At its core, informed consent helps protect patient autonomy, which is the ethical principle that individuals have the right to make decisions about their own bodies and medical care. Informed consent also supports ethical medical practice. Healthcare professionals are expected to act in ways that respect the dignity, rights, and preferences of the patients they serve. Without informed consent, patients could be subjected to treatments or procedures they did not fully understand or might not have chosen if they had been properly informed. There is also a significant legal component to informed consent. Healthcare providers and institutions are legally responsible for ensuring that patients are properly informed before treatments are performed. Failure to obtain informed consent can lead to legal consequences, including malpractice claims. But beyond the legal aspects, informed consent plays an important role in building trust between patients and healthcare providers. When patients feel that their questions are answered and their choices are respected, they are more likely to feel confident in their care and maintain a collaborative relationship with the healthcare team. Ultimately, informed consent reinforces the idea that healthcare should be a shared decision-making process, rather than a system where decisions are made solely by providers. The next concept we need to discuss is capacity to consent. Before a patient can provide valid informed consent, they must have the ability to understand and evaluate the medical decisions being presented to them. Capacity refers to whether a patient has the mental ability to process information, consider the available options, and make a decision about their care. In healthcare settings, capacity is usually evaluated by physicians or other qualified healthcare professionals, particularly when there are concerns about a patient's cognitive ability. For example, patients who are unconscious, severely confused, heavily sedated, or experiencing significant cognitive impairment may not have the capacity to make medical decisions. In those situations, healthcare providers may rely on surrogate decision makers, such as a healthcare proxy or legally appointed guardian. It's important to recognize that capacity is not an all or nothing condition. A patient may have the ability to make some decisions, but not others. For example, someone might be able to decide whether they want to take a medication, but may not fully understand the complexities of a high-risk surgical procedure. This is why capacity assessments are often decision-specific and situation-specific. Let's look a little more closely at what capacity actually involves. In order to have decision-making capacity, a patient must be able to perform several important cognitive tasks. First, they must be able to understand the medical information being presented to them. This includes the nature of their condition and the treatment options available. Second, they must be able to evaluate the risks and benefits associated with each option. This means considering how the treatment might affect their health, quality of life, and long-term outcomes. Third, the patient must be able to communicate a decision. This could be verbal, written, or even through nonverbal methods if necessary. Another important point to remember is that capacity can change over time. For example, a patient who is temporarily confused due to medication or illness may regain full decision-making capacity once their condition improves. Because of this, healthcare providers often reassess capacity when there are changes in a patient's medical status. Understanding capacity helps ensure that medical decisions are made by the appropriate individual, whether that is the patient themselves or a legally authorized decision maker. Now let's look at some situations that may affect a patient's ability to make healthcare decisions. A patient's capacity to make medical decisions is not always constant. In fact, there are several medical and situational factors that can temporarily or permanently affect a patient's ability to understand information and make decisions about their care. One example is severe illness. When someone is critically ill, especially in intensive care settings, their physical condition may interfere with their ability to think clearly or process complex medical information. Another factor is cognitive impairment. Conditions such as dementia, severe developmental disorders, or certain psychiatric illnesses may affect a person's ability to understand medical information and weigh the risks and benefits of treatment. Brain injuries can also impact decision-making capacity. Traumatic brain injuries, strokes, or neurological disorders may impair memory, reasoning, or communication. Finally, sedation or medication effects can temporarily affect a patient's cognitive function. Patients who are heavily medicated for pain, anesthesia, or anxiety may not be able to provide valid consent until the medication effects wear off. These situations highlight why healthcare providers must carefully evaluate a patient's capacity before accepting consent for significant medical decisions. If a patient lacks capacity, healthcare teams must rely on advance directives or surrogate decision makers to guide treatment decisions. When there is uncertainty about whether a patient can make decisions for themselves, healthcare providers perform what is called a capacity assessment. This evaluation focuses on several key abilities that indicate whether a patient can participate in medical decision making. First, the patient must be able to understand the relevant medical information. This means they can grasp the basic details about their diagnosis, treatment options, and the purpose of the recommended intervention. Second, they must be able to appreciate the consequences of their choices. In other words, they should recognize how a decision may affect their health and future outcomes. Third, patients should be able to reason through their options. This means comparing risks and benefits and explaining why they prefer one option over another. Finally, the patient must be able to communicate a clear and consistent decision. Communication may occur verbally in writing or through other methods if necessary. Capacity assessments are designed to ensure that medical decisions are made by individuals who truly understand the implications of their choices. If the patient cannot meet these criteria, healthcare providers may turn to surrogate decision makers or previously documented patient wishes. Another extremely important ethical principle in healthcare is the right to refuse treatment. Patients have the legal and ethical right to decline medical interventions, even if those treatments might prolong their life or improve their health. This principle is grounded in the ethical concept of patient autonomy, which recognizes that individuals have the authority to make decisions about their own bodies. From an ethical standpoint, healthcare professionals must respect these decisions as long as the patient has decision-making capacity and understands the consequences of refusing treatment. For example, a patient may decline surgery, chemotherapy, blood transfusions, or other medical interventions for personal, cultural, or religious reasons. One commonly cited example involves patients who refuse blood transfusions due to religious beliefs. Even if providers strongly believe the treatment would be beneficial, they must respect the patient's decision if the patient has the capacity to refuse. This can be challenging for healthcare providers because their training emphasizes saving lives and preventing harm. However, respecting patient autonomy means acknowledging that patients have the right to choose their own course of care, even when those decisions differ from medical recommendations. This brings us to one of the foundational principles of healthcare ethics, patient autonomy. Patient autonomy refers to a person's right to make decisions about their own medical care based on their values, beliefs, and personal preferences. Autonomy is considered one of the strongest ethical principles in modern healthcare because it recognizes that patients are not simply passive recipients of care. Instead, they are active participants in decisions that affect their bodies, health, and lives. One key aspect of autonomy is the patient's right to refuse treatment, which we discussed in the previous slide. But autonomy also includes the right to accept treatment, ask questions, request second opinions, and participate in discussions about their care plan. Healthcare professionals play an important role in supporting patient autonomy by providing clear information, answering questions honestly, and ensuring patients feel respected in the decision-making process. Ultimately, ethical healthcare practice requires balancing professional expertise with respect for the patient's individual choices. When patients feel heard and respected, it strengthens trust, improves communication, and leads to more collaborative and compassionate healthcare relationships. An important extension of patient autonomy is the right to refuse medical treatment. In healthcare ethics and law, competent patients have the right to decline treatment, even when that decision may lead to serious harm or even death. This can be difficult for healthcare professionals to accept because our training emphasizes preserving life and preventing harm whenever possible. However, ethical healthcare practice recognizes that patients ultimately have authority over their own bodies and medical decisions. Refusal of treatment can take many forms. For example, a patient may decline blood transfusions, often for religious reasons. Some individuals may refuse ventilator support or other life-sustaining treatments. Others may decline surgery or aggressive medical interventions, especially when the potential benefits are uncertain or the risks are significant. When a patient refuses treatment, healthcare providers must ensure that the refusal is informed. This means the patient understands the nature of the treatment being declined, the potential consequences of refusing it, and any available alternatives. Once those conditions are met, providers are ethically and legally required to respect the patient's decision, even if they personally disagree with it. While the right to refuse treatment is well established in healthcare ethics, it can create challenging situations for healthcare providers and families. One common challenge occurs when family members disagree with the patient's decision. Families often want everything possible done to prolong life, even when the patient has clearly stated that they do not want certain treatments. Another difficult situation arises when healthcare providers believe treatment could significantly help the patient. Providers may struggle emotionally with respecting a decision that appears to limit the patient's chances of recovery. There may also be cases where religious or cultural beliefs influence medical decisions. These beliefs may guide patients towards refusing treatments that healthcare providers consider routine or life-saving. In these situations, healthcare teams must balance respect for patient autonomy with their professional responsibility to provide compassionate care. This often requires clear communication, careful documentation, and sometimes consultation with ethics committees or legal advisors to ensure that decisions are handled appropriately and respectfully. Ultimately, ethical healthcare practice requires recognizing that medical expertise does not override patient choice. Now let's consider situations where patients are unable to make medical decisions for themselves. Some patients cannot participate in decision making due to medical conditions that affect consciousness, cognition, or communication. These patients are often referred to as incompetent patients. Although modern terminology increasingly uses the phrase patients lacking decision making capacity. Examples include individuals who are in a coma, those with advanced dementia, patients with severe traumatic brain injuries, or individuals with certain developmental disabilities that prevent them from understanding complex medical information. In these situations, the patient cannot fully understand treatment options or communicate a clear decision regarding their care. Because of this, healthcare providers must rely on alternative decision-making processes to guide medical care. These processes are designed to protect the patient's rights while ensuring that important healthcare decisions can still be made when the patient cannot participate directly. The goal is always to make decisions that reflect the patient's values, preferences, and best interests as closely as possible. When patients cannot make decisions for themselves, healthcare providers turn to surrogate decision-making systems. These systems allow another person to make medical decisions on behalf of the patient while attempting to honor what the patient would have wanted. Common examples of situations where surrogate decision-making is necessary include patients in a coma, those with advanced dementia, individuals with severe brain injuries, or people whose cognitive disabilities prevent them from understanding medical information. In these cases, decisions may be made by legally authorized representatives, such as healthcare proxies, durable power of attorney for healthcare, or family members designated by law or hospital policy. The guiding principle for these decisions is often called substituted judgment. This means the decision maker attempts to choose the option the patient would have selected if they were able to speak for themselves. If the patient's wishes are not known, providers and surrogates may rely on the best interest standard, meaning they select the option that most reasonably promotes the patient's health, comfort, and dignity. These systems help ensure that even when patients cannot speak for themselves, their care is guided by ethical principles that respect their rights and well-being. When patients cannot make medical decisions for themselves, healthcare providers must rely on substitute decision makers, sometimes called surrogate decision makers. These individuals are responsible for making healthcare decisions on behalf of the patient. The goal is not for the surrogate to decide what they personally prefer, but rather to represent what the patient would likely want if they were able to speak for themselves. There are two primary ethical approaches used in substitute decision making. The first is substituted judgment. This approach asks the decision maker to consider the patient's values, beliefs, and past statements about medical care. Essentially, the surrogate asks, what would this patient choose if they were able to decide right now? For example, if a patient previously expressed that they did not want aggressive life-sustaining treatments in certain situations, the surrogate decision maker should attempt to honor those wishes. The second approach is the best interest standard. This is used when the patient's preferences are unknown. In these cases, decisions focus on what would most benefit the patient medically while minimizing suffering and preserving dignity. Both approaches aim to ensure that decisions remain patient-centered even when the patient cannot actively participate. When substitute decision making is required, healthcare teams carry significant ethical responsibilities. First and foremost, decisions must prioritize patient dignity. Even when patients cannot communicate, they still deserve respect, compassion, and thoughtful care that recognizes their humanity. Healthcare teams must also consider patient preferences whenever those preferences are known. Advance directives, prior conversations with family members, or documented treatment wishes can provide valuable guidance. Another key factor is medical appropriateness. Healthcare providers must evaluate whether a proposed treatment is medically reasonable and likely to provide benefit. Treatments that offer little chance of improving outcomes may not be ethically appropriate, even if requested. Finally, decisions must follow ethical standards and professional guidelines. Hospitals often rely on ethics committees, institutional policies, and interdisciplinary discussions to ensure that complex decisions are handled responsibly. These decisions rarely occur in isolation. They typically involve collaboration between physicians, nurses, laboratory professionals, ethics consultants, and family members. The goal is always to reach decisions that balance medical expertise, ethical principles, and respect for the patient's rights and dignity. Although laboratory professionals often work behind the scenes, they play an important role in the ethical delivery of healthcare. Laboratory testing frequently guides critical medical decisions, including diagnoses, treatment plans, and life-sustaining interventions. Laboratory professionals contribute to patient care in several key ways. First, through diagnostic testing. Accurate laboratory data helps physicians determine the nature and severity of disease. Second, through quality control practices. Maintaining strict quality standards ensures that laboratory results are reliable and safe for clinical decision making. Third, through accurate reporting of results. Clear, timely, and precise reporting allows healthcare providers to interpret laboratory findings appropriately. Finally, laboratory professionals are responsible for the communication of critical values. When results indicate life-threatening conditions, immediate reporting allows providers to intervene quickly. Although laboratory professionals may not interact directly with patients, their work plays a crucial role in ensuring that medical decisions are based on accurate and trustworthy information. Ethical laboratory practice supports the entire healthcare system. The ethical responsibilities of laboratory professionals extend far beyond performing technical procedures. Laboratory professionals influence clinical care by ensuring that diagnostic information is accurate, reliable, and communicated appropriately. Every stage of laboratory testing carries ethical importance. For example, quality control procedures help prevent inaccurate results that could lead to misdiagnosis or inappropriate treatment. Accurate reporting ensures that physicians receive correct information when making decisions about patient care. Additionally, laboratory professionals must communicate critical values quickly and clearly so that healthcare teams can respond to urgent medical conditions. An error in laboratory testing can have serious consequences. Incorrect results may lead to delayed diagnoses, inappropriate treatments, or unnecessary procedures. Because of this, laboratory professionals carry a profound ethical responsibility to maintain precision, honesty, and accountability in their work. Even though laboratory professionals may not always meet the patients they serve, their work directly affects life-altering medical decisions. Ethical laboratory practice ultimately protects patient safety and supports the integrity of the healthcare system. Ethical laboratory practice is grounded in several core professional responsibilities that guide how laboratory professionals perform their work every day. The first is accuracy and reliability of results. The data produced in the laboratory directly influences diagnoses, treatment decisions, and sometimes life-saving interventions. Because of this, laboratory professionals must follow validated procedures, maintain instrumentation properly, and consistently verify that quality control measures are functioning as expected. Even small technical mistakes can lead to incorrect results that affect patient care. The second responsibility is honest documentation. Every step of the laboratory process must be recorded accurately, including specimen handling, testing procedures, instrument calibration, and result verification. Ethical documentation means recording what actually occurred, even if the process did not go perfectly. Attempting to hide mistakes or alter documentation can compromise patient safety and violates professional standards. Another key responsibility is clear communication. Laboratory professionals must ensure that results are reported in a timely and understandable manner so that healthcare providers can make informed clinical decisions. This becomes especially important when results indicate critical or life-threatening conditions. Finally, Ethical laboratory practice includes questioning unexpected or unusual results. If a value does not match the patient's clinical picture, laboratory professionals should investigate the possibility of specimen issues, technical errors, or instrument malfunction before releasing the result. Together, these responsibilities protect the most important priority in healthcare, patient safety. Laboratory professionals regularly encounter situations that require ethical judgment and careful decision making. One example involves reporting questionable results. If a laboratory value appears inconsistent with the patient's clinical condition or other laboratory findings, the technologist must decide whether additional verification is necessary before reporting the result. Ethical practice encourages investigation rather than simply releasing a result that may be incorrect. Another situation involves pressure to rush testing. Healthcare environments can be busy, and clinicians often need results quickly. However, rushing through procedures can increase the risk of technical errors or overlooked quality control issues. Ethical laboratory practice requires balancing efficiency with accuracy, remembering that reliable results are more important than simply producing results quickly. Documentation errors also create ethical dilemmas. If a mistake is discovered in laboratory records, it must be corrected transparently and according to institutional policy. Acknowledging errors may feel uncomfortable, but transparency is essential for maintaining trust and ensuring patient safety. A final example involves critical values in patients receiving end-of-life care. Laboratory professionals may question whether certain test results will change treatment decisions. Even in these situations, laboratory staff must follow established reporting protocols while allowing the healthcare team to determine how the information should influence care. These scenarios illustrate that laboratory work requires professional judgment, ethical reasoning, and accountability. Ethical decision-making in healthcare is rarely simple or straightforward. Healthcare professionals often face situations where multiple ethical principles must be considered simultaneously. For example, a decision that benefits a patient medically may conflict with the patient's personal preferences, or a decision that respects autonomy may raise questions about potential harm. Because of this complexity, professionals must learn to apply ethical principles thoughtfully rather than mechanically. One important step is identifying which ethical principles are relevant to the situation. Concepts such as autonomy, beneficence, non-malfeasance, and justice help guide decision-making and provide a framework for evaluating options. Effective communication is also essential. Ethical decisions often involve collaboration among physicians, nurses, laboratory professionals, and sometimes ethics committees. Sharing information clearly and respectfully helps ensure that decisions reflect multiple professional perspectives. Another key consideration is respecting patient wishes whenever possible. Advance directives, prior conversations with family members, and documented preferences can help guide decision making when patients cannot communicate directly. Finally, professionals must maintain professional integrity. Ethical practice requires honesty, accountability, and the willingness to address problems openly rather than ignoring them. In healthcare, ethical decision making is not just about following rules. It is about thoughtful judgment guided by professional responsibility. Let's take a moment to summarize the key concepts from today's lecture. First, end-of-life decisions involve complex ethical considerations. These situations require healthcare providers to carefully evaluate patient wishes, medical appropriateness, and ethical principles while balancing emotional and clinical factors. Second, patient autonomy plays a central role in medical decision making. Whenever patients have the capacity to make decisions about their care, their choices must be respected, even when healthcare providers may personally disagree with those decisions. Another important concept is informed consent. Patients should receive clear explanations of treatment options, potential risks, expected benefits, and alternatives so they can make decisions that align with their values and preferences. When patients cannot make decisions themselves, surrogate decision makers help guide care using either substituted judgment or the best interest standard. Finally, laboratory professionals contribute to ethical healthcare through accurate and responsible practice. The results produced in the laboratory influence diagnoses, treatment plans, and patient outcomes. Even though laboratory professionals may not always interact directly with patients, their work remains a critical part of ethical and responsible healthcare delivery. Healthcare professionals are trusted not only for their technical knowledge and clinical skills, but also for their judgment, integrity, and ethical responsibility. Patients and families depend on healthcare providers to make decisions that prioritize safety, compassion, and respect for human dignity. This responsibility extends to every member of the healthcare team, including laboratory professionals. Laboratory professionals may not always see the patients whose specimens they analyze, but their work still plays a direct role in patient care. Each sample represents a person whose diagnosis, treatment plan, and health outcomes may depend on the accuracy of laboratory results. Ethical reasoning helps ensure that medical decisions reflect professional standards, patient dignity, and responsible clinical judgment. Maintaining ethical practice means consistently asking important questions. Are the results accurate? Have procedures been followed correctly? Have unusual findings been investigated? These questions reinforce the idea that ethical laboratory practice is not only about technical skill, it is about accountability and respect for the patients we serve. Ultimately, ethical practice protects both patients and the integrity of the healthcare system. Brings us to the end of today's lecture. As you review this material, remember that healthcare ethics is not simply an abstract concept. Ethical principles directly influence how healthcare professionals make decisions, communicate with patients, and perform their professional responsibilities. For laboratory professionals in particular, ethical practice means maintaining accuracy, honesty, transparency, and accountability throughout every stage of the testing process. It also means recognizing that laboratory data plays a critical role in guiding medical decisions. Physicians, nurses, and other healthcare providers rely on laboratory results when diagnosing disease, monitoring treatment effectiveness, and responding to critical patient conditions. Because of this, laboratory professionals carry an important responsibility to ensure that their work reflects the highest professional standards. As you move forward in your education and careers, keep in mind that ethical decision making will be part of everyday professional practice. Technical expertise is essential, but professional integrity is what ensures that expertise is used responsibly. Thank you for your attention today, and I look forward to continuing these conversations as we explore more aspects of professional practice in healthcare.